Hello, and welcome to our webinar, Applying Person-Centered Planning and Thinking Principles in the Delivery of Supports and Services for Persons Living with a Traumatic Brain Injury, offered by the National Association of State Head Injury Administrators. I'm Carrie Bennett, Chair of NASHIA's Training and Education Committee, and Gabriela Lawrence Soto is our webinar organizer today. Thank you for joining us. If you're unfamiliar with NASHIA, we are a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. A GoToWebinar user guide is available for download from the NASHIA website. This is a great resource for making the most of your live webinar experiences. A handout of today's presentation is available for download. Please check your attendee control panel for the handouts pane. To ask a question during the webinar, please enter it in the questions pane, and our organizer will forward your question to our speaker after the presentation if time allows. If we run out of time, the presenter will respond to your question via email. Today's webinar is the third and final in our series on person-centered planning. These webinars are free to view, but if you would like a certificate of participation to use in pursuing continuing education credits, please note that NASHIA members and non-members may purchase them at the NASHIA website. All webinars in this series will be recorded and archived at the NASHIA website to view for free. Today, our presenter will provide tips and tools for adapting person-centered planning and thinking approaches when working with individuals who are living with a history of brain injury. Encouraging choice and autonomy is important in the development of meaningful goals and the application of strategies and accommodations critical to reaching goals for work, home, and community life. Our objectives today are to describe the essential differences between the medical model approach to treatment and services and the person-centered approach, to utilize a tool to assess the level of person-centered practices of programs and services, and to apply tools and strategies to enhance their program's person-centered competency in terms of staff approach to service delivery in a person-centered manner. Before we begin, we have several poll questions for our audience. Gabby, would you like to launch the first poll question? Our first poll question for you, please respond by selecting yes, no, or sometimes. In your organization, participants are encouraged to invite supporters to meetings. Gabby, what did our audience say? Wonderful. Most of you indicated yes. 92% of you said that your participants are encouraged to invite supporters to meetings. And some people have a place or have a ways to go, but that's great. How about question number 2? In your organization, is each participant receiving a copy of their individual plan? Yes, no, or sometimes? What are our results, Gabby? Again, most of you indicated yes. That's wonderful. And this is good information, by the way, for your speaker today. So thank you for answering our poll questions. How about number 3? Participants' goals are written in their own words in their individual plan. Yes, no, or sometimes? What did our audience say on this question? More divided this time. Looks to be about half and half, with some folks saying no too. So that's interesting information. How about question number 4? Participants' goals for their life are included in their individual plan. Yes, no, or sometimes. How did our audience respond to this one? Again, most of you indicated yes. That's wonderful. We have a final question for you. Participants prepare with staff in advance of their meeting. Yes, no, or sometimes. And how did our audience respond to this one? Sometimes. Okay. So perhaps our presenter will address that particular topic in her presentation. Wonderful. Thanks, everyone. All right, well, let's get to it. And now I'm very pleased to introduce our speaker, Anastasia Edmonston. Ms. Edmonston is a training and workplace development professional who's experienced in designing and delivering workshops and classes on a wide range of topics related to behavioral health and disability. Since 2003, she has been responsible for the development and dissemination of educational products for use by professionals, family members, individuals living with brain injury, advocacy groups, and community providers as a TBI and person-centered planning trainer. She provides training around the state and nationally to a variety of audiences, including providers of mental health, substance abuse, brain injury, and developmental disabilities services, the Division of Rehabilitation Services, and local area agencies on aging and Center for Independent Living staff, as well as law enforcement and public safety professionals. Welcome, Anastasia.
Good afternoon, and good afternoon to the audience. Thank you so much, Gabby and Carrie, for inviting me to this webinar, and thank you to NASHIA. I'm going to dive right in here. I would be remiss if I did not give a lot of thanks and credit to the work and guidance that I have been privy to by Diane Greeter, who did the second in the series. I've been working with Diane since 2011, and with Lisa Meyer, who was the first presenter in this series, and she's with the learning community, and I've known Lisa for about 2 years, and between both of their models, I've been able to adapt and weave in person-centered planning principles and approaches when working with professionals who serve individuals living with brain injury, as well as help me introduce brain injury related topics to my colleagues who work in mental health and addiction. So today the message is, of course, we're going to talk about being holistic, because that is what being person-centered is. And I'm going to share some tools and strategies and some resources for you. It's no sense in reinventing the wheel. I hope that I can give you some ideas that you can just run with, the minute after you get off of this webinar. Interestingly, when I first started training on this topic, that one of the first presentations I did for a brain injury audience was at our annual Brain Injury Association of Maryland conference. And the workshop was entitled Integrating Person-Centered Planning into the Delivery of Brain Injury Services. The target audience as indicated on the conference workshop, and it was intended to be for professionals. That day, I walked into a pretty full room, and it was evenly split between professionals and individuals living with brain injuries. And I did not get even a quarter way through my presentation as I ended up facilitating a de facto support group of individuals who were living with brain injury who felt the services they had received in the past or were currently receiving were not person-centered. And that was so educational and informative to me and the other professionals in the room. So I came away with that really reinforcing the notion that people living with brain injury, their families and caregivers need to be educated about person-centered principles and practices and what they should reasonably expect in terms of person-centered practices. So that when they go to check out maybe a post-acute program, they can have some good guidance in the back of their minds as to what they can expect. Is this a person-centered environment? Is my loved one, or am I really going to be the center of the services as we encourage in implementing person-centered practices? So in terms of brain injury and person-centered planning and person-centered thinking, historically not a lot in the literature. And I go back every few years. I went back recently in preparation for this webinar, and there's not a lot in the literature. That is there is around person-centered planning in pediatric brain injury services, and adult acute care, and some intensive acute rehabilitation, but not a lot in terms of comparing it to the availability of resources in the world of intellectual disabilities or in mental health. There have been some products that have been developed over the past few years. I do want to point you in the direction of the Mount Sinai Research and Training Center on Community Integration of Individuals with Traumatic Brain Injury. That's one of our TBI model systems program, and Dr. Gordon and his colleagues have done some nice work in this area. In the past, they've collaborated with Beth Monch, who's considered a subject matter expert on person-centered practices, and they do have some really good resources and materials on their website that you can check out. But when I train, I frequently quote Dr. Gordon, because I think understanding how this model is different when you're working with people living with brain injuries is that they had a before and after. So you always need to factor that in. So if you want to move on, of course, you want people to move on and be able to survive and thrive post-traumatic injury, but you have to be respectful that individual or those people need to deal with who I was in addition to who I want to be post the injury. Now, this next slide's a little busy, and I'm not going to go into a great deal about all of them, but I have put these side by side because I do think they reinforce the messages, even though they are kind of coming from different points of view. So Diane, and when she trains, and I know she referenced it in her webinar, she talks about the stages of change, and that's a model I'm sure many of you are familiar with, and you have to meet people where they are and understand if they are in any way ready to engage with services. And it has been traditionally used with people who are dealing with behavioral health or especially addiction issues. And I do reference you or direct you to John Corrigan's work at the Ohio Valley Center, because years ago he and his colleagues adapted the stages of change and motivational interviewing through the lens of working with individuals with brain injury. So I think that's something that is really important to understand where people are in terms of what their goals are and what they need in terms to reach those goals. Diane says that in the mental health world, the treatment plans tend to be written as if somebody's in the action stage, like they're ready to take charge and follow the recommendations of professionals. But in fact, they're still in pre-contemplation. In other words, I'm fine, you all, I'm not buying what you're selling. I would argue in the world of brain injury services that we should look at that middle model, the stages of rehab and TBI recovery. And this is from Dr. Yehuda Benishay from the NYU, New York University brain injury, used to be called the head trauma program, the brain injury program there. And so this is an excellent model, I think, for understanding the process of moving through rehabilitation after brain injury. And I would argue that sometimes we as professionals write goals as if people are in the mastery stage, like why isn't he using his notebook to help, or using his PDF, or using his cell phone in order to use strategies to, say, even make appointments. We expect people to jump on the mastery level when perhaps they are still in that lack of awareness or unawareness of the injury imposed barriers, and so cannot use the strategies and supports that we recommend. Meeting people where they are in terms of the stages of rehab and TBI, as laid out by Dr. Benny Shea, is key to establishing a person-centered therapeutic alliance. The NYU Head Trauma Program is, again, a really good way of framing where people are. So, for example, many of you who have worked in the field of brain injury service have worked with people who are insisting, for example, that they be given their keys back to their vehicle because they don't recognize the consequences of a visual field neglect or a delayed reaction time that will make driving for the immediate future unsafe. Like pre-contemplation, individuals with poor awareness can learn about their strengths and the injury-imposed barriers, but they have to be engaged in the rehab process. And even for those who are unaware due to the extent or nature of where their brains were injured, building that therapeutic alliance, that clinical alliance with professionals and others using a person-centered approach can help people. And I've seen this in my own work. You can guide people to adapt strategies even when they are not fully buying in yet. And that really helps move them along towards autonomy and eventual awareness. And so they can then adapt more and become even that much more competent and independent. Of course, I threw Maslow in there because it's just universal, his messages. And I have used all of those, in working in groups of people living with brain injury, and it just makes sense. And especially the stages of rehabilitation, I strongly urge you, if you do group work and with folks who are at a newest stage of rehabilitation, say they just come from an inpatient program, there's a method to our madness here in rehabilitation. We want to get you engaged, establish some relationship with your fellow clients. This is what we're going to work on. And I have found that for people coming into rehab, this has been a real way of shedding light on the stages of getting back to where they want to be, to their identity. And I've had nothing but good feedback when I've used this in group settings. So the critical elements of implementing person-centered planning or thinking with people who are living with traumatic brain injury, and this is adapted from the TBI Consumer Report from the Mount Sinai program. This is report number 8, and it's no longer on their website from what I can see, but perhaps you can shoot them an email to get a hold of it. But they do have 2 other tools for engaging in person-centered planning that were published and disseminated in 1998 and then again in 2003. There's a workbook for individuals with brain injury, and there's a second manual for those who are providing that circle of support. So I definitely urge you to look for that. Lisa Meyer shared several tools that are incredibly useful to encouraging people to express their choices, hopes, and dreams during her webinar. And if you didn't catch that, you might want to listen to the archive, but she talked about the relationship map, and that is an awesome tool to incorporate into your work so you know who are the important people in the individual's life so that you can bring them into the team. So you want to expand that person's circle of supports and have people who are meaningful to them. I found this quote years ago, and I include it because the woman who's speaking is addressing kind of our people if you work in the brain injury rehabilitation world. She's talking to newly minted speech therapists, and she's really encouraging these students ready to be professionals to work in a holistic manner. A dear friend of mine and colleague, she embodies this advice when she treats individuals living with a brain injury. She is a speech therapist, and she tries not to give people work and worksheets and tasks that don't have any personal meaning. So she gets to know them, their interests, their careers. For example, if she's working with somebody who had been an attorney prior to their injury, she will adapt law books and articles and questions from the law school admission test into her therapy sessions and assignments. And that is really embracing person-centered therapeutic practices for people who are reluctant to engage in therapy. Using something that is familiar and meaningful to them is an incredible bridge to having them address some of their injury-imposed challenges. So I would argue that it's never too soon to implement person-centered approaches, even in the medical setting. So early in my career, I worked with individuals in a rehabilitation skilled nursing center in Boston, and we worked with folks who were literally just emerged from coma. And in our vocational groups, and I do want to give credit to my former supervisor, Pat Price, because she really taught me that we need to encourage people to think of themselves as workers, not patients. And you can take simple steps towards autonomy, even in very institutional, medically focused environments. For example, what we did is we encouraged people to strip their own beds and put the dirty sheets, if they were able to physically, in the linen bags and not let the nursing staff do it for them. So really encouraging people to move from a patient role to a worker role, even in that setting. And at that time, it required a big change in mindset, not only for the individuals, but for the nursing staff, some of whom didn't get it at first. But once they were brought into the conversation around moving away from a patient identity, they were essential in reinforcing the message that what you can do for yourself, you should do for yourself. So we brought in the skilled nursing assistants as our part of our team, even in that early setting, to encourage person-centered approaches and autonomy, even given the limitations in an inpatient setting. So this is just my way of kind of framing, as Carrie mentioned at the onset, the medical model versus the person-centered. So you want to move away from policies and attitudes that focus on fixing people, that meet people where they are now. So just to compare and contrast, the medical model is the white coat and they're the expert. In the person-centered model, the person knows best. We want to focus on the whole person, not just on their range of motion, for example, in our brain injury world. Involves delivery of care to the person, but we want the person to care for themselves. So in that very first example I just gave you of people being asked to strip their own beds in the morning, that's something you can do for yourself. That's something that you would do if you were back at home and taking care of your own business. And then in the medical model, oftentimes it can be very focused on one-to-one meetings. So our speech therapists will work one-on-one, our OTs will work one-on-one, but in the person-centered, you really want to have a team approach to services. So this, and I totally understand that this is a big change for those of us who grew up in the brain injury world, at any rate, working initially in hospital-like settings. So moving on to the next slide. So I think that even when folks are still in post-traumatic amnesia, they're still going to register tone of voice. They're going to register the attitude of respect conveyed to them by professionals and others around them. So we really need to communicate with families and supporters and the person themselves directly. Once they've moved past the stage of unconsciousness, and as soon as they can tolerate, they should be included in all discussions. So the example for this is there was a woman that came through a program that I was working, and I was coordinating that program. And this is a very highly skilled professional person who had a pretty catastrophic injury, but she was able to engage, she was able to respond, and was sitting at the table with her husband. And when we were going around the room talking about her progress and all the different modalities, that the speech therapist did not address her. She addressed the husband. And I could see it registered on the individual's face. And we had a staff meeting afterwards to just reinforce the importance of speaking to the person. But never speak as if somebody is not in the room. And this is one article I did find that's fairly recent. And this is involving work done in Scandinavia. It was in the Scandinavian Journal of Occupational Therapy, and it's a small study. They used semi-structured interviews with 6 individuals in treatment for moderate to severe traumatic brain injury around what they valued about person-centered practices as they relate to the experience of being in occupational therapy. And the conclusion the authors reach is that occupational therapists, and I quote, should value and invest in the development of relationships with clients, whilst the importance of seeking and integrating the client perspective into practice and research is affirmed for the profession. In other words, this is evidence-based approach to be person-centered. And you can see from the really quite beautiful quotes that they included in the abstract to this article. Finding my place in life, adjusting to who I am now, and sharing my journey. That's what I'm looking for when I'm working with a professional. So person-first language. People are not a diagnostic label. You are not brain injured. You're not brain damaged. You are a person living with a brain injury. You're not a schizophrenic. You're a person living with schizophrenia. Focus on strengths, successes, and talents, and self-determination as a right. And I do want to talk a little bit more about that. When working with individuals whose cognitive and or neuropsychiatric challenges related to their injuries, it can be tricky because sometimes they're not able to comprehend. How do we balance important to and important for? So I'm going to give you an example. A young woman whose dominant side was affected after her traumatic brain injury insisted to everyone at the outpatient program that she didn't need rehab. So this was somebody who had very little awareness of her injury-imposed barriers. And she just needed to return to work in the deli department at a local market. Not one of us said to her, that's unrealistic. You can't use your right arm or leg like you used to. We did say, we are worried about your safety based on what your physical therapist and your employer tell us about your duties in a fast-paced environment. And that included slicing meat and cheese with a huge machine. Typically would have arranged for an on-site evaluation with a vocational specialist, but because of those safety concerns, the employer would not allow for an on-site evaluation. So how do we help create awareness so this individual would realize that maybe there are other choices beyond the one that she wants to go back to? And it's understandable, she worked in that job for many years. So our vocational specialist created an ad hoc assessment of speed and fine motor agility, and this individual agreed, those are 2 things that are really important for this job, by creating stations on tables around a large room that had tasks such as collating, stapling, using paper clips according to a set of directions. And we had normed these tasks using several staff people. So the timer went off and she knew what she was to do. And after about 10 minutes of going up and down the room and trying to do these tasks, she just sat down, threw her hands up and said, there's no way I can go back to the market. She said, I gotta look at plan B. And she decided that she wanted to go back to school. That had always been a dream to finish her college education, and she did. So the key here was honoring her wishes, letting her make the decision. She was in on the planning of this assessment and encouraging her to think about alternatives. So I'm going to give you a few more examples. So when conducting this training in person, I don't highlight the team. I ask the participants this question, what is wrong with this statement? And this is taken right from the records of an individual for whom I was providing administrative case management, who's receiving Medicaid brain injury waiver services. And so, of course, the team is what's wrong, because the team was finding this individual was staying up too late and making life difficult for the overnight staff because he had too much coffee. And so they decided it would be a good idea just to cut back rather than having a discussion with the individual. And if I am to be honest, I've been in this field for over 30 years. If I look back at notes I'd written when working in clinical settings, I am sure I was also guilty of using such paternalistic language. Now, on the flip side, this is from the same provider, so it really does depend on who's writing the note. But this individual The key word here is the right part about the statement is our wants. This individual incurred injury while pursuing an advanced degree in a highly technical scientific field, challenges with her physical functioning, as well as her language as a result of her injury. But she really wanted to be in an academic setting, so she, with the support of her staff, audited and attended several lectures at a local university. And that made all the difference to her. So more about person-first language. So I was at a team meeting, and again, I was acting in the capacity of the administrative case manager on our waiver. And this individual had very compromised memory skills. He never recalled meeting me from encounter to encounter, very disinhibited verbally and physically, but he was working for the first time in a long time. He was sober, had a good relationship with his family, and really was stable for the first time in a long time. And this should have been celebrated at the meeting. Yet instead, the case manager came in late, the on-site case manager, and she said, every time I walk in his room, I see his collection of plastic cups all over the place. He needs to clean up. And I thought, boy, way to take the air out of the room. And so I said, well, maybe there's something I'm missing here. So I asked her about the cups. I said, are the cups dirty? She said, no. Are there bugs or vermin in his room related to this cup? No. Was he taking the cups that might have been otherwise used by staff and his roommates at the house, taking more than his share of cups? No, she said. So I said, hey, I'm wondering, it's his room. He likes cups. There's no reason for the cups to be anyone's business other than his own. And he turned to me and he said, I don't know who you are. And then he turned to the other people in the room and he said, but what she said. So, even somebody who is in long-term post-traumatic amnesia, who has a hard time hanging on to information, he heard what I said in terms of an alternative way of dealing with the cups. So the cups stayed. No more talk of cups. Dr. Nelson, I'm kind of going to be shifting a little bit here to documentation. So Dr. Nelson is a doctor and a psychiatrist, actually, and she's also addressed the topic of person-centered, non-judgmental language for professionals. And her guiding light is consider how you would want yourself or a loved one to be described in the record. So the use of electronic records, it is great. People have access to their records. They're able to keep in touch with their treating providers, and she says the use of patient-centered, non-judgmental language will better preserve the patient-physician alliance. And there has been some studies to show that people who have access to their medical documentation are more compliant in terms of recommended medication or other things that the doctor or the provider has suggested. However, I have a word of caution just based on my experience and one I put on your radar, and that is that when you get into big systems, even small providers sometimes, you end up with a checklist. And checklists tend to be written in medical and rehab jargon and are not exactly person-centered or accessible. Even if I did go to my portal, if I'm reading a checklist, chances are it might not be in language that I'm going to understand. So this can be a barrier to the implementation of person-centered practices and planning. So a few years back, I was working with a small group of transition-age youth who had a history of brain injury, substance abuse, and mental health issues. And this young woman was at a program I had worked at, and at that time when I was there 10 years prior to, we had a very nice person-centered plan, a narrative that was in their own words and described what they were working on. But now it was a checklist. So now her treatment plan was a checklist. And it was a fine checklist. And granted, the discussion at the meeting was very person-centered. The feedback on her services and how she felt was elicited and discussed. But that robust conversation was not reflected in the medical records. And that's not right. Another instance, I was talking to with a colleague. We were providing person-centered planning training to outpatient mental health providers, and I was told to I was told that they had a great checklist that the person signed. And when I questioned that, they said, we need that because we don't have time to write it. And I asked them, if you give the person a copy of their plan, and you guys seem to be doing that, granted from the poll, but I was told by the staff there that the copy machine was not in a convenient place for them. So I'm going to move along because I tend to be wordy, but I wanted to just highlight the self-assessment that is one of your handouts. And Janice Tindora and Miller of the Yale Program for Recovery and Community Health in Connecticut has created 3 of these, and Dr. Tindora gave me permission to adopt it for the brain injury community. So I'm not going to read this to you, but you can see this is exactly where the poll questions came from. So please feel free to take that and use it with your individuals. You can also kind of change the lingo to be modified so the patient, excuse me, listen to me, the program participants can assess their programs and services, and their family members can. So to create a person-centered plan, the assessment needs to be comprehensive. In order to, it needs to create a plan with meaningful interventions. And what I say to people who work in behavioral health is you need to be brain injury informed. You need to know if that person had a history of brain injury. And then I would flip it over to the world of brain injury. If you want to be very sure you're being person-centered, you need to assess folks for a history of addiction and behavioral health, as well as any learning disabilities that they may have had prior to. Individual that was served in an inpatient program that I worked at, severe injury, had cognitive challenges, could not vocalize because of his brain injury. And the team was just struggling with him in terms of addressing his aphasia. He was very resistive, would skip out on therapy. And when talking to the family in the first meeting, they said, oh, he had dyslexia. He never liked being in anything that felt like school to him. Knowing that really was useful in creating an approach that was more acceptable to that individual. Whoop. So I'm going to talk about John. So this is just an example of a plan, a component, and Diane did touch upon this in her webinar. So this is an individual living with a history of brain injury and a behavioral health disorder. So he's somebody who was very heavy drinker for many, many years. But now he's working. He's working at a landscaping crew in a public facility. Excellent work, productivity, very diligent. However, he does swear when annoyed at coworkers and his boss. And as I said, this was in a very public place. He also had some other behaviors that weren't acceptable in the workplace. So what does his plan look like? I want to keep my job. That is his goal. So we talk about the goal being in the person's own words. It's that simple. In the poll, 42% of you said yes, and 47% said sometimes, and 12 said no. So for the goal has to be in that person's words, ideally, and short and simple. So obviously this individual, from what I've described briefly, has disinhibition and lability. And those are common after brain injury, especially frontal and temporal lobe involvement. So back in the medical world, his goal might have been, John will reduce, inappropriate comments over 8 hours by 3% or 4%, whatever, that very therapeutic, rehab-y jargon. But for this guy, the basic goal was, I want to keep my job. I don't want to talk about disinhibition. So the objective would be he will yell or throw less than 3 times a day. So really concrete, because if he's yelling, he's not going to keep his job. And then what are the interventions? Those are the services that will be provided. Those are the strategies he's going to use. It identifies the therapist and the staff people that he's going to work with. So it's very, very concrete. Okay, so being brain injury centered means being brain injury informed. And I'm going to just mention that for those of us who worked in this field for a long time, It's good to know if that person is coming to us just for services. Has there been another brain injury prior to the one that has brought them to you? And I have examples where it really was good to know, say, that one individual we worked with had a history of 3 injuries in childhood, which really contributed to the final one when he was a young man. So, building a plan. I took this from Diane, and it is through a brain injury lens. So when you're working with people living with brain injury, you still screen. You want to know how that brain injury history informs their behavior. You want to prioritize through that brain injury awareness lens, what are their needs. So one individual who did have a lack of awareness, and that is key when we're talking about life after brain injury. Again, that awareness can be a barrier. He wanted to get along with his roommates, but in the house he was living in, he kept barging into their rooms. Drilling down with the staff, found out he couldn't read, so he didn't see the name on it. So I said, can he read a picture? Can you look at a picture of his own face? We put that on his room. Oh, okay. So he didn't have to be aware per se that he was barging into somebody else's room. He just needed to look at his face and match it with himself and go into that room only, therefore improving his ability to get into his own room, and more importantly, not to anger his roommates, because it was a nice group of folks, but they were getting a little tired of it. So I'm just going to wrap up by just talking about some tools. So I know that Lisa talked about the one-page description. This can be a standalone document. It's a great overview of important to and important for the individual. And I'm going to show you 2 examples. This one is definitely through a brain injury lens. So this is kind of a composite of our Transition Age Youth Pilot Project. And so this is an individual who had, again, the composite, but not too far from what a lot of us, work with. An individual who had a pre-existing mental health issue, an individual who had some developmental delays even prior to the injury, and he's working. But it's good for the staff to know what are the supports that he needs, what is important to him. And probably the most important is what the staff who work with him need to be. So in my composite, this individual is working with a individual support staff person who provides support employment and also case management, and lives in his neighborhood. So really culturally aware, understands the location of where he lives, some of the challenges that presents, because in Baltimore City sometimes can be, a bit dangerous for somebody like, an individual who wants to lecture people on good behavior. So it's probably not a good and safe thing to do in all circumstances. This next one is one that I actually used for a family member who was living with dementia, and she couldn't really share her wants and needs. I gave this to the nursing home day one, put it in the front of her chart, put it up on her closet, and she's been there 2 years, and they still refer to her as Nurse Jean. They reference the names of her children because that's on her person-centered plan. I obviously modified it for privacy, but it really gives them a way to connect to her because she does understand some things. So learning about support. So when I train, I'm just sharing with you some real simple things that you can use. If anybody's heard me talk about training resources before, and I use something called a clip from a movie called The Lookout, which is about a young man 4 years post brain injury, and played by Joseph Gordon-Levitt. But I will show a clip from it. I have created a narrative summary based on the character of, his name is Chris. I have people read the narrative summary. I have them watch the clip, think about writing goals and objectives and services for this individual. I want them to think about the barriers the injury has imposed. What are his strengths? What is he using to compensate for already? What is he already have in hand, and what can we build upon? And have them create a very short person-centered plan for a fictional character who probably looks a lot like the individuals that they've served over the years in the brain injury world. And also it's a good one to educate behavioral health professionals about what living with a brain injury could look like. I oftentimes start my trainings with this wonderful video, Florence and the Machines, The Dog Days Are Over, but it shows you a series of pictures. First you see individual's face and their diagnosis, and that goes through a number of individuals, and then you see the same individuals over again with a description of their strengths and a little bit about them, and that's what that slide there is. But the initial slide that showed his picture, it just said schizophrenic. So it's really just highlights the importance of person-centered language, and it's kind of a nice thing to start off a training with. The other great video that is talking about empathy versus sympathy illustrates how to approach people who may be in crisis or in a tough place. Could not necessarily be from a brain injury, but for anything about empathy versus sympathy and how we meet people where they are. Unmotivational interviewing. I put this into a training when I feel people are getting tired and need a laugh. How not to be person-centered. And it's funny, there's a little bit of truth in it, though Bob Newhart's playing a very obnoxious therapist and very unperson-centered to the extreme. There are strains of what I think most of us are familiar with in terms of people not feeling listened to. So it's just a nice educational yet humorous clip. And then SBIRT, which is screening, brief intervention, and referral to treatment. That's been suggested, and actually they're training in our state on this model among physicians and different providers to try to get a sense if somebody is using or abusing alcohol and illicit drugs. And even if you're not there to talk about substance use related issues per se, they show you in this clip a doctor who could care less about where that individual is, who managed to get himself in a not too serious injury related to a car accident because he'd been drinking. And then you have the doc who is very person-centered and listening and asking questions and just trying to get a sense of where that individual is in relationship to understanding the impact of his substance use on his life and the consequences of that substance use. So I'm gonna wrap up with my content. And if there's any questions, I'd be happy to entertain them. I guess I would have to say that I have more resources than I wanted to inundate NASHIA with. If you ever want to give me a call or check out anything else I have that you might want to use, just shoot me an email. I'll be happy to share with you anything that I have done that I have permission to share. Both Lisa Myers and the learning community and Diane have been very generous in allowing me to modify their materials for use in the brain injury community.
Thank you, Stacia. Wasn't that a wonderful webinar, folks? Thank you.
Yeah, sure. Thank you. I hope it's going to be useful for folks.
I'm sure it will be. And just a reminder to everybody, it will be recorded, or it is being recorded, and it'll be posted up on the NASHIA website along with Stacia's handouts probably in a few days. It might take us a few days to get it there, but it'll be there. So wonderful. Thanks again, Stacia.
Sure. And I don't think I mentioned that narrative summary for the character in The Lookout. I'm happy to share that with anybody. So if you want to get a hold of the DVD and use that, and I would also suggest it's not just for professionals. I found when working in groups, sometimes it's easier to look at, a fictional character's struggles and strengths than it is to look at, your own in the moment. It's a little bit too close to home, but to have that kind of experience. So how would you help this gentleman? You know, what kind of supports do you think he needs to deal with the results of his brain injury? How would you help him, you know, prepare for a more challenging job? So I'm happy to share, you know, the narrative summary that I created and with anybody who's interested.
Great. And so folks can contact you directly. I think your contact information was on one of like your last slide. And
Yes.
so, or they can sure contact us at training@nashia.org and we will get that message over to you for that request.
Thank you, Carrie.
Yeah, thanks, Stacia. Well, and thanks everybody for viewing our webinar today. Please think about joining us in Des Moines, Iowa this fall for the 29th Annual State of the States and Head Injury Meeting, which will be sponsored by NASHIA. You can email us at training@nashia.org to join our contact list and receive notice of future webinar offerings. And to view our archived webinars and much more, please visit the NASHIA website. And finally, if you're interested in joining NASHIA, we'd love to have you. Please contact Rebecca Wolfkeel, our Executive Director. Thanks again for viewing our webinar today, and please remember to complete your evaluation when it pops up on your screen. Thanks again.